Hi, my name is Zach Anderson. I'm a neonatologist at Winnie Palmer Hospital for Women and Infants at Orlando Health, and I'm here to speak with you about ultrasound-guided vascular access in the NICU. Briefly, the objectives are just to review the literature on both venous and arterial access using ultrasound in the neonate, detail some of the widespread limitations to its use in the neonatal population, and show basic ultrasound-guided cannulation techniques and some videos I've taken over the years. I have no conflicts of interest. Just for a quick background, I think we are so used to vascular access, we don't think of it that often, but it's the most frequent invasive procedure in the NICU. There's a tremendously high failure rate. We don't entirely know how high it is. Often there's undocumented attempts, and often we're hearing about attempts even after 5, 6, even 10 pokes on a baby. And so we're not entirely sure how high, but we tend to be pretty unsuccessful at this procedure compared to other procedures we do like airways. We accept a high failure rate of IVs, but not as much with airways, which is an interesting paradigm. And this is a term that keeps coming up in the literature for difficult intravenous access patients, abbreviated to DIVAs, which is an interesting term, but I think represents our patients very well. They're small, their vessels are small. They've often been instrumented before. Patients who have cardiac disease or renal disease often have very tortuous and difficult to cannulate vessels. And so our population is a difficult one for access, and that sort of sets the background for what we'll speak about next. Arterial access is probably the more well-studied between venous and arterial access in neonates using ultrasound. This is a nice randomized control trial comparing an experienced neonatologist landmark and palpation techniques versus ultrasound techniques. And they found that there was a higher success rate in the ultrasound group, again, in the hands of experienced practitioners, fewer attempts to success, 1 versus 2, and no difference in the time between the two as well. This is another randomized trial performing essentially the same exact study. However, they did find a decreased amount of time for procedure in the ultrasound group would be the difference that this one adds. And this is a nice study by Shazia Bombel's group when she was still at Stanford, demonstrating in a retrospective chart review manner, looking at both landmark and palpation techniques versus ultrasound, and found that there was increased first success attempts, and particularly in novice practitioners, so people with less than 5 years of experience in neonatology, this versus landmark techniques tended to be more successful. And I think that's salient for teaching fellows and things like that, that this often using ultrasound may be a better way of performing this procedure in small neonates using ultrasound versus the traditional sort of landmark technique. So in summary, really increased success with first attempts using ultrasound, 68 versus 38 in that one study I'd mentioned, decreased attempts with ultrasound versus technique, no difference in procedure time, and an improved novice proficiency. Looking at venous access, it's a bit different. We see a lot of extrapolation from pediatric data and incorporation of the neonatal population into studies using pediatric patients, which, as all of you know, neonates are not pediatric patients even. And so looking at a lot of that data and extrapolating down to it is most of what the literature we're looking at is. However, there's some evolving data that's coming out and some international and national guidelines looking at neonates in particular, also advocating for the use of ultrasound. We'll go through some of those as well. This is just a nice review paper looking at really the advantages of using ultrasound in newborns specifically. And so identifying that often we're poking these babies blindly, probably striking structures underneath the skin that are sensitive, nervous tissue, bone, all these different things that we often hit using a blind technique that with ultrasound you can avoid. And this, I think, was a nice kind of paper to look at. So why would we even consider doing this in our patient population? There's some compelling information in there. A lot of the critics of using ultrasound in neonates say it's too difficult in small babies. And I think as the technology has evolved with the linear probes, as well as sort of our skill with using ultrasound, babies are getting smaller and smaller that we're using. This was a nice paper written in 2016 by some of our surgical colleagues documenting really using ultrasound for PICC lines in babies under 1.5 kilograms. And typically this technology was reserved for patients greater than 2 kilos. And so as babies get smaller, we've been able to demonstrate in the literature, at least, and in practice, that we are able to cannulate these patients smaller vessels, whether it's an artery or a vein. The mini magic guidelines were a set of guidelines that came out of Michigan, helping to guide practitioners for the best access to use in their patients. This is mostly targeted towards pediatric patients and particularly hem-onc patients. However, there was several recommendations for neonates in particular. All of them were advocating the use of ultrasound for not only short-term, so peripheral IVs or midlines, but also for PICC lines and longer-term access for placement for those patients as well. And I think one of the more robust papers I could find on this was in 2012, as early as 2012. Our intensive care colleagues, really from across the ocean in Europe, having some recommendations on ultrasound guided vascular access, and detailed specifically in neonates and children. Again, lumping those two together, that both for short and long-term central venous access, we should be strongly considering using ultrasound, particularly if you look at the second cell there, for patients who have difficult peripheral IV access. And again, I would mention that that's probably the majority of our patients if you look at the amount of attempts we perform on them for IV access, just routine peripheral IVs or for PICC lines. And the third point down there is specifically for arterial catheterization, recommending that, again, this should be done using ultrasound in children and neonates. And again, that's a technique and a recommendation that our adult and pediatric colleagues have been following for years now. So we're sort of latecomers to using these techniques. Summary for the venous access sort of literature is that the guidelines, international and national, using ultrasound as a standard of care. There's many feasibility studies that are published and unpublished, quite frankly. We've been using ultrasound at Winnie Palmer now, using them in smalls babies down to 500 grams. I know that we've been cannulating with using ultrasound that are difficult IV sticks. I would say that a big hole in the literature is ultrasound versus landmark techniques for comparing the two for PICC lines in particular. That's the lion's share of central access we utilize in the neonatal population. And so I'm not seeing a lot of studies comparing those two head to head. I didn't detail them a ton, but there's a multitude of literature detailing the superiority of ultrasound in centrally inserted central catheters. So IJs, brachiocephalic lines, subclavian lines, fem lines, all of those have been shown in neonates and pediatric populations that there's a far superior success rates and decreased complication rates when comparing ultrasound to landmark. So it sort of begs the question, why aren't we all using ultrasound? And I think a lot of y'all will have, you could help add to this list probably for me, but there's just been a slow adoption. Our anesthesia colleagues have been using ultrasound for different techniques for vascular access since the 80s, our emergency medicine colleagues since the 90s, and really since the early 2000s, pediatrics have started to incorporate this, and slowly as the technology has evolved, I think we've gotten there. But neonatology has been lagging behind our other colleagues in terms of adoption of ultrasound technology for access. It's not a part of fellowship training often, and so often people are either self-taught or self-motivated and go to classes, but it's typically not something you're taught in fellowship. Unless you train at a place that has someone, an attending who's an expert, then often you don't get any of this type of training. A lot of neonatologists in particular just have discomfort with trusting what they're seeing on ultrasound. And so trusting that what they're poking is actually an artery or actually a vein, making sure that really what they're seeing is what on the ultrasound is what is really being poked with the baby, is often a source of discomfort and shies people away from using it. Access to an ultrasound device is not an insignificant one. These are expensive machines. The linear probes are quite expensive, and often hospital systems, particularly for smaller NICUs, are not willing to pay to have a dedicated ultrasound machine for just this access alone. If really ultrasound guided vascular access is the main goal of it, and so often this can be a large barrier. The high frequency probes have really come a long way. Really, even in about 5 years or so, when I trained in fellowship, the probes we had went as high as 12 megahertz, which for a baby is often very difficult to see their vessels with. even large ones. And now there's companies manufacturing linear probes that are much higher frequency and have better resolution. So I think this problem will go away, but has been a hindrance in the past. Time and money. This is, again, like I said, often a capital investment from the institution that can be pricey and can be um, hard to obtain, quite frankly. And it also takes time. It takes time to learn how to do this procedure, it takes time to fail, and it takes time to maybe go to other places who are able to teach you how to do this. And so that's not insignificant in a busy practice, or in a practice where there's lots of people who don't have a lot of extra time to give because they're involved in other things. And a kind of administrative one, but an equally important one, is proficiency and credentialing. Who's proficient in these procedures? Who's credentialed? How do you assure that they can prove those things is important, and particularly important to hospital administrators who want to be sure that people are doing this safely and doing it well. Like I mentioned, and I have pictured here a probe from GE. This is the one we use, and I have no affiliation with them, but you can see on there L10 to 22, that's the megahertz. And so it goes up to a 22 megahertz, what we call like a ultra high frequency linear probe, which has great resolution. I'll show you in some videos coming up. But often before that, it was impossible to see neonatal vessels. I think this is also difficult because there's lots of techniques around these. So this is a Seldinger technique using a wire and a needle to thread a catheter through into a vessel. This is called the modified Seldinger technique, which uses a introducing needle and a soft catheter, which then you thread a wire through and advance a catheter down onto. There's different angiocasts. There's Gelcos, there's these BD ones, there's specialized arterial access catheters like this from Vigon, or like this from Arrow. And I think this just adds layers onto it that makes people not really that interested in getting into the nitty-gritty of performing these procedures in patients. And so all these things sort of work against us, I think, in some way. The technique is not that difficult in theory, but in practice often is. And so on the left, you'll see the in-plane approach. This is often not used in our patients. This is when the needle goes along the long axis of the ultrasound beam, so you can see the needle the entire time. This is an appealing technique, you would think, because you can see the needle the entire time. However, I find in practice our patients' arteries are so small, and it's very difficult to line up everything and see the needle, get the vessel, and kind of have all those in plane with the ultrasound beam. So most of what we're doing is on the right, which is called out of plane or short axis views of the vessel, where you see a dot and you fan the ultrasound probe away, and I'll show you that on the next slide as well. But the majority of things we'll be doing, and what I'll be showing in the videos after this, is short axis or out of plane ultrasound cannulation. This is a quick little video. If you look on the top, that's sort of a gross picture as the needles advance down towards the vessel. And on the bottom is what you might see on ultrasound. And so as the needle gets closer and closer to the vessel, you can see the image generated by the ultrasound shows it slowly dropping in to the vessel. And that final image is what you call a bullseye sign. And so what you're looking for is to, again, watching the image on the bottom, getting the needle closer to the vessel serially as you slide the probe over. And I'll just point out that it's very important to move only the needle or only the probe independently. If you're moving both, it's very hard to track the needle tip. And so tracking the needle tip or following your needle point it's called different things. Walking the dog, people call all sorts of funny things, but is the most crucial part for out of plane, because if you continue to push the needle in, you won't actually know where the needle tip is. And so the whole point of this is to visualize the needle tip. Once you catch the mid shaft of the needle right there, you move the probe forward until the white dot or the hyperechoic area and your ultrasound is gone. And I'll show some videos of that. This is a patient who's about 1.3 kilograms, so probably representative of a fair amount of our patients. And you'll see the sort of my hands, and then you'll see a paired ultrasound image of it. And I'll try to talk you through what I'm doing here. And so you can see I've got sterile gloves, a sterile probe cover, sterile drapes here. As I poke the patient, I lose the image a little bit here. I'm going to pause it here. This is the radial head. This is the skin. This is a little bit of gel that you're catching on the side here. And this is the radial artery that I'm compressing. And you'll see as I lighten up, it pops up into view. So what you're looking for is here, the needle tip, and here is my radial artery, which again, I've compressed a little bit. And so what you'll see me do is slowly start working the needle to the left to hopefully get towards that radial artery and lighten up on my touch. So the radial artery pops open. Let's see it pop open there. And that dot just to the right of it. So I'm swinging left. And right now I'm in the middle. That's the bullseye sign. And I start to chase the vessel down and to the right. This is a really tortuous vessel. And you can see I have a flash already in the catheter. Not much, or maybe hard to see in that picture, but I continue to chase the vessel down to the right, slide the catheter off, have a nice bright flash, and then I'll attach the hook up here. This is probably, your bread and butter patient who you're doing arterial cannulation on. So, small, but not that small. And in times past, I thought that this was maybe the extremes of the patients we could cannulate. This is a different kind of patient, a very large patient who had hypoxic ischemic encephalopathy and had oliguric renal failure, was extremely edematous. And you can see on the ultrasound image that there's quite a bit of subcutaneous tissue. And these patients are really hard to do from a landmark perspective because you can't feel their vessels. And so this is a larger patient. She was almost 5 kilos when I was doing this procedure. And this was with a sonocyte device. So you can see it looks a little different, a little less image quality, a little not as great image quality. Again, I lose the image there when I poke, but this is the radial artery. This is the radial head. This is the skin up here. And there's probably about maybe 2 millimeters of subcutaneous tissue right there before you can actually see. This is my needle once I pop through. So watch the needle here as I realize I've gone a little too deep. Start to shallow out the angle of the needle and pop serially into the vessel. That's right in the middle of the vessel. And I scan forward, move the needle forward, scan forward, advance the needle, scan forward, advance the needle. And you repeat this process until you have a flash, which you can see there's one in the image on the right, or you feel comfortable enough to advance a catheter straight down into the patient, or sometimes with the assistance of a guide wire. I've kind of gone away from guide wires, but in this video, I was still using them. And so you can see I just continue to march it into the vessel, getting a fair amount of purchase into the vessel. And I grab you can see there's arterial blood, and then grab a guide wire to try to advance it after I put that down. You can, that's a 22 gauge angiocath. You can fit an arrow wire through there, which is a 0.018 inch diameter wire, but through 24 gauges, you can fit a Cook wire through, which is 0.015 inch diameter wire. And so you can see I hook it up there and are able to get it into quite a edematous patient. This is the smallest baby I've captured on video. That is a 410-gram baby. The smallest baby we've been able to do at Winnie Palmer's was 325 grams on 2 inotropes and a dorsalis pedis artery. This is just a radial artery, and this is the smallest baby I've been able to capture on video, and it just sort of demonstrates some of the difficulties of it. So that's the baby's wrist right there. It's hard to see. And I'll orient you to the ultrasound image that pops up on the left. So you can see here, excuse me. As we pop through the skin, this is the radial artery here, and this is the radial bone again here. And you'll see all the black up here is actually jelly. And so in these smallest patients, because it's so easy to compress their radial artery, you often have to float the probe on top of their skin with a little bit of ultrasound gel. And this is the radial artery here. Once I pop through, I end up below the vessel, if I remember right. You can see I'm poking, moving the subcutaneous tissues. Here's the needle. You can see I'm below it here. And it looks like a far distance, but in practice, I don't have the calipers up here. It's probably a 0.5 millimeter. And so I'm backing up, shallowing out the angle. I'm coming up and to the left. So you can see here's the needle and here's the vessel. Again, here's the needle. And then in 2 seconds, you'll see it in the vessel. So again, nice open vessel here. And that's the bullseye sign we're talking about, right in the middle, And you continue to advance the catheter here. You can see there's a little blood as I've kind of entered the vessel. And the flash is not as apparent in this, but as I continue to march it down into the patient's vessel, it starts filling up the catheter length here. And you can throw the catheter down into the baby. There should be no real resistance here. And I keep the needle in so these small babies don't lose a lot of blood, just to staunch the blood as it comes out, and attach your flush. Okay. These are my sources. That's the end of my presentation, but I would invite you to consider using ultrasound for different vascular access applications in your unit, and to seek out training if no one exists in your institution that does it yet. And so my email will be at the end of the talk as well. I'm happy to speak with anyone about my experience and what I'm still learning through this process. I'm by no means an expert. I just end up doing it a lot, and I feel like I'm learning a lot as we go. And as the literature catches up to what we're doing already, I think we'll start to see more and more people move towards this. So I appreciate your time, and I will hopefully you guys enjoy the Delphi conference. Thanks.